Moreira, Assistant Professor of Medicine at Northwestern University Feinberg School of Medicine in the Division of Hematology Oncology, where my clinical practice mainly focuses on hematopoietic stem cell transplantation. I have the distinct pleasure and honor of introducing our main speaker for this track, Dr. Ricardo Correa. Dr. Correa is an Associate Professor of Medicine and Program Director for Endocrinology, Diabetes, and Metabolism Fellowship, as well as the Director for Diversity and Graduate Medical Education at the University of Arizona College of Medicine. Dr. Correa serves as a staff clinician and researcher at the Phoenix Veterans Administration Healthcare System and faculty at Mayo School of Medicine at Mayo Clinic, Arizona. He's an editor of Dynamed, Society of General Internal Medicine Forum, Journal of General Internal Medicine, Frontier Endocrinology, Thyroid, Clinical Thyroidology, among many other journals. He is board certified in medical quality, is the author of the book titled Case Report, Basics and Publication, and senior co-editor of the book Endocrinology of Aging. He completed his internal medicine residency at Jackson Memorial Hospital at the University of Miami program, where he was honored as an AOA recipient and with the Gold DOC Award. Then he pursued his clinical and research fellowship in endocrinology with a particular focus on neuroendocrinology and adrenals at the National Institute of Health. He's taken an active leadership role in multiple national organizations, including the American Medical Association, the Accreditation Council for Graduate Medical Education at different levels, including the Duty Hours Task Force, National Board of Medical Examiners as part of the board, and other organizations. Also serves as a member of the Committee on Publications Ethics and World Association of Medical Editors. Dr. Correa has been awarded numerous recognitions, including Presidential Leadership Scholar, 100 Hispanic Inspiring Scientist, Medscape Rising Start, Humanitarian Award by Arizona Medical Association, AACE, Endocrinology Rising Star, and many other prestigious national awards. Dr. Correa, we're honored and thrilled to have you join us, and we're very excited to hear your talk.
Oh, thank you so much, Dr. Moreira, and it's a real pleasure to be here with all of you and share a little bit of our experience on working with Latino communities. And let me just share my screen. Okay, so again, thank you so much, Dr. Moreira and to Mola for the invitation. We are going to go let you know about a program that we started in Rhode Island and then moved to Phoenix and continue with this and trying to address some of the chronic disease, in this case, diabetes and metabolic syndrome in a patient with a Latino community. So basically, I want to start this with the increased awareness that certain societies has become in the last years. So here you can see the American Diabetes Association guidelines. And it started in 2020. They start the last part of the algorithm where they put social determinant of health, in this case, the cost as a major issue. So not every algorithm that of certain management of this issue will see this, but this is where now societies that are creating new guidelines and new algorithms are also putting social determinant of health and healthcare disparities in as part of their algorithms. So we all know that metabolic syndrome is a very common condition, and that can contribute to definitely increased type 2 diabetes and cardiovascular disease. So people that suffer from metabolic syndrome has twice experienced adverse events in cardiovascular outcomes and 4 times more opportunity to have diabetes. And we know that this is disproportionate in patients in marginalized communities, including Latinx more than any other of the communities. So the risk factors are multiple, but include a behavioral part, but also include a genetic components, and also include some other conditions, hypertension, dyslipidemia, high morning glucose that can affect these patients. When we see the Hispanic or Latinx community in the US, we know that the behaviors are changing, and then there is some risk of higher metabolic syndromes and higher metabolic dysfunction on these patients. This cause some higher levels of cardiovascular disease, higher levels of prevalence of diabetes, and the cardiovascular risk factors. There was a concept that is not true that is called the Latino paradox, where patients were having more were patients that were having more events like the Latinos or cardiovascular events and the diabetes. There were some studies in the 80s and 90s with the Mexican Americans that showed that the death rates were less. But later on, some studies done in comparison, the same population in Latin America show that this is not true. So this Latino paradox do not translate really to the 2021. So whenever you hear that term, it's not true anymore. Lower access to healthcare screen and care, it's very important because then the mortality is influenced there. And then it definitely, we know that the Latinx is more is an ethnicity where these represent a different variety of cultures, place where you were born, and socioeconomic status. So if we compare some data of metabolic syndromes from different groups, we can know that Mexican American females have higher risk of dyslipidemia, higher fasting glucose and waist circumference than non-white, non-Hispanic white. And then the Mexican American males have higher rate of fasting blood glucose compared with the non-Hispanic males. Also, if we see in the Latinx community, there has been an increase in the last 30 years of 38% of metabolic syndrome among patients in the United States, the Latinx communities in the United States, basically. And some behavioral factors, we can see that when we analyze the Latinx community in the United States, not in Latin America, but in the United States, we know that the consumption and smoking are lower compared to other race and ethnicity, but the sedentary behaviors and physical inactivities are higher. This do not translate to Latin America. We know the alcohol consumption in Mexico is the higher in the entire continent, and smoking consumption in the rest of Latin American countries is very high compared with other race and ethnicities. And when we translate also dietary, we understand that the Latinx community has more eating of sugary beverage compare with the other race and ethnicities, and definitely there is less healthy food in their diet, so less fruits, less vegetables per serving sizes. So all of this create a problem in the Latinx community. So all of this contribute to have some diabetes, metabolic syndrome that will translate definitely this to cardiovascular outcomes and death. And we know that there are some community-based intervention that has worked basically in the non-Latinx community. And then this project was mainly trying to translate and acculturate that community-based interventions to some specific underserved Latinx community. So basically, in the community interventions, it's a combination of multiple areas, including the education of the patient, but also the education of the healthcare system, and also providing some stability regarding, for example, food insecurities and jobs. So we know that 15.8% of the Hispanic families suffer from food insecurity, and this can be translated to the food banks that, incredible or not, they don't have low sugar or low carbs diet. So basically, patients that have diabetes and depends on food banks, they just get a full of carbohydrates meals. So just I wanted here to mention that really from the majority, if we compare how much time each Latino spend on health, if 6 hours of the year are spending in the doctor office only, and the rest of the time is spending on health, diet, physical activity, monitoring blood sugars, managing their own health. So really we have to focus on their time that they are doing this by their own, than instead of focusing on their time that they're spending with the doctors, because it's less amount of time. So this program was, as I mentioned, started in a clinic in Rhode Island called Clinic Esperanza. Basically, we're a translation of a program called Thumbs Up from Dr. Oliveros, and basically focus on basic social cognitive theory, where communities serve as the support system for this entire population. We are dealing with mainly underserved and undocumented immigrants that do not have access to any healthcare systems, and they go to these community clinics where the resources are limited, and then you have to focus more on trying to create programs to decrease or to prevent the progression of some of the disease, in this case, metabolic syndromes and diabetes. The program is based in community healthcare workers that they are called navegantes, and they are the ones really that administer the program to the patient. So it's a very simple program. Everything is based on thumbs up or thumbs down, and it's to also improve health literacy in the community. So the program is adapted from the English to Spanish, and it's for 4th graders and up. So it's a very basic concepts, but what you can see is that the beginning of the program, the concept of the patients is totally different when they end. So we increase the health literacy, definitely, but the Latinx community have different settings that when this program was applied in English. So we have a lot of more thumbs up when we see an overweight male or female than when the non-Hispanic whites were seen an overweight male or female. So it's a program that is divided in 2 parts. The big part is the program that is applied to the patients, and this is 8 weeks. Definitely it's not a long-term program. It costs some money, so we have to spread it into time, and then basically we are trying to expand these 8 weeks to really a 1 year, 52 weeks program. So the participants definitely comes from the different areas. For example, they come referral from others providers in the clinic. They come because they heard that somebody was participating and they want to participate. The big component of this are the navegantes, and I will let you talk to you about a little bit more. And in our first cohort, we have a grant, and with that grant, we were able to compensate at least with $10 if they come to the first session, and $10 if they come to the last session. Also, learning more about some healthcare disparities. So we develop a program where they have childcare if they come to the program. So each of the patients are paired in a group of 10 or 12 with the navegantes. The navegantes go over all the program with them, and basically they are the ones that run the show. They are the ones that have 70% of the discussion. They are the ones that really provide all the care. They are oversight by the program's leaders, but really the navegantes are the ones that runs all the show. And navegantes, where they are coming from, are from the community. They can be, now that we have some cohorts, they can be some participants in prior cohort, or they can be some persons that have the disease and want to help their communities. So this is just an example of some group meetings from the different navegantes and from part of the staff of the clinic. And then really this is the most important part. So training the navegantes, because these are the people that are going to translate this information to the patients or the participants of the group. So basically there is a program for them. It's a 10 weeks program where you have multiple other things besides teaching just the program. There is medical interpretation, there is life coaching, that they will teach them about the diabetes prevention programs, and the most important thing for them is that they get a certificate certificate at the end of this training, and then they can help as medical translators. They can help as coaches later on in their career. And this is just very excited whenever they receive their certificate and their advancement in their careers. So then what is the program started? So we train the navegantes, then the navegantes are the ones that are going to go to the 8 weeks program with their participants in each group. So the first visit, basically the navegantes run, as I mentioned, run the show. They do all the surveys, they do the biochemical work, and then they sometimes they are the ones that help us drawing the blood. Other times we send it to the labs in the clinic. And then in the follow-up meetings, it's a meeting where the group decide what they want to do. Before COVID pandemic, everything was face-to-face or in person. And then this was where the group decided to 2 hours per week. With the pandemic, the program has been slower. It's a little bit more difficult to arrange these meetings via Zoom. Some of them do not have access to all of the services of internet and all of that. So has been a little bit more struggle. We still are returning back again to certain normality in the clinic in Phoenix. So we are going back to some of the events, and definitely there were a lot of social events, and social events can occur not just with one group, but multiple groups that comes together. And then that's where I think the beauty of the program, where the community center became the center of the community. So basically there was people that start teaching Zumba. They were not expert, but they start teaching this kind of exercise. And then there were participants there. There was the priest that comes and gives some spiritual guidance. There was the involvement of local cookers or chef in the community, and then comes and teach how to eat healthy. So everybody has a part. Everybody knows when you are part of the program, and then the rest of the community try to help you to achieve the goal of finish the program. And then we finish in the program, increasing health literacy and some outcomes. And definitely in the final session, we measure again the baseline characteristics and the survey. Up to now, there are more than 400 participants that we have had. The majority of them, I will not say all of them, but the majority of them, probably 97% of them has been Hispanic, mainly Spanish speaking, not English fluent. And then we have half of them completed the entire course of 8 weeks. Some of the results that we have had is just that in 8 weeks, that is a short term for a diabetes prevention program, but in 8 weeks, we have had the most impressive health literacy improvement. And this is more because of the community help than anything else. And we have some improvement, not definitely big improvement, because in 8 weeks, it's very difficult to see some of these changes, but in the continuity, for example, of the first cohort that then start being navegantes and now continue pursuing this thing, we have seen a bigger impact. So weight loss, BMI improvement, waist circumference improvement, decrease in A1C, and improving dyslipidemia and blood pressure. One of the limitations that we all have had in this program is that we don't have a comparison group. And that's something that we need to do better so we can prove that definitely this intervention works when compared with another with a comparison group. We don't have that, but just be comparing among the groups, it's a big improvement. And something that we thought will help a lot was the telehealth, but really for our community that sometimes, as I mentioned, is limited in resources, it doesn't work so much. And then sometimes the program have to be expanded a lot more because there is no time to meet because of the limited resources, not being in person. So this is just a quick example of a program that was translated from English to Spanish. Of course, it's not the translation only, but it's the acculturation that is very important, because when I was in Rhode Island and we were running this program, there was a different kind of population, of Latinx population, more from Dominican Republic and Puerto Rico, so from the Caribbean. And then there was a lot of the things in the book were referring to food that they eat, different from I moved to Phoenix and I tried to start the same program. It was not translated the same, the acculturation was different. So I have to change that and say, focus more on the culture of the Mexican American, Central American that live in Phoenix. So again, it's not just a translation sometimes of programs, but it's a acculturation with the type of Latinx community where you live in, and this has been probably the success. We see the same results that we did in that community in Rhode Island that we are doing in the community in Phoenix, and we're trying to expand to other places. So thank you so much, and it was a real pleasure to show you this project, and hope to hear from others that are doing something similar.
Thank you very much, Dr. Correa, and I don't even have to activate the 2-minute warning bell. So you kept it right on time. In the interest of moving forward, what we're going to try to do is have our 2 oral presenters present right now, and then please feel free to jot down any questions or include them in the chat box. Actually, we encourage the latter, and we can explore the discussion section utilizing those questions at the end of the session. So our next presenter is Celine Breggio, I'm sorry. She is a 2021 Mola Michael Reese Foundation Scholar and currently a medical student at the University of Chicago Pritzker School of Medicine. Student Dr. Breggio, please go ahead.
Let's see. Can you all see my screen? And can you all hear me okay? All right, perfect. So hi, everyone. Thank you, Dr. Moreira, for the warm introduction. I'm excited to be here today presenting on the impact of language concordance between physicians and patients in cancer care. I have no disclosures to share, so let's jump right in. Approximately 9% of the United States population has limited English proficiency, or LEP. Several studies have shown that LEP patients experience more challenges in attaining quality care and have worse health outcomes due to communication barriers. In fact, patients who receive care from providers who don't speak their language have been shown to have decreased access to preventative services, satisfaction with care, understanding of goals of care, and treatment adherence. Studies have also demonstrated that matching patients with a language concordant clinician and working with professional interpreters can effectively reduce the healthcare disparities for LEP populations. In the field of oncology, physicians and patients especially engage often in sensitive, complex conversations that include the communication of bad news, discussions about prognosis, and jargon-heavy medical information related to treatment options. It has been established that communication between physicians and patients is a therapeutic component of the doctor-patient relationship, and that effective doctor-patient communication contributes to better treatment outcomes. When language discordance exists between an oncology patient and their cancer care provider, this therapeutic component of their relationship can be negatively impacted. And actually, language discordance in oncology care has been associated with limited knowledge of cancer diagnoses, delayed cancer treatment, and inadequate information about clinical trials and recruitment. I also want to note that we are defining language concordance as patient-physician direct communication, and therefore it is separate from patient-physician interpreter triad. And this is because, as I mentioned before, direct communication between physicians and patients is what sets a foundation for that partnership and therapeutic relationship. And having a third person in the room definitely affects that dynamic and can come with its own set of unique challenges. It's important to note, though, that professional interpreters and fully language concordant clinicians have been shown to reduce disparities for LEP patients. However, despite knowing this information, research has shown that clinicians underuse language services in favor of their own often limited non-English skills. So although communication is such an important aspect of cancer care, no studies have used direct observation to assess the quality of communication across language barriers. And that's where RIAS comes in. RIAS, which stands for the Rotor Interaction Analysis System, was developed by Dr. Deborah Rotor at Johns Hopkins University and is a well-validated and commonly used tool for assessing communication quality. RIAS uses qualitative coding to extrapolate factors such as topics of conversation, statements of empathy, and verbal cues of understanding from audio recorded medical interactions. And these qualitative factors can later be quantified into utterances or the number of times that the speaker said something or engaged in the behavior of interest. This system has previously been used in cancer care, but to date, it has only been used in patient-clinician interactions that are language concordant. Which brings me right into our objectives. In this pilot project, we set out to use the RIAS to describe the nature of communication between clinicians and LEP cancer patients, and then investigate the impact of language concordant care for patients presenting for an initial oncology visit. In our study, we had a total of 50 participants, 34 patients and 16 physicians. Patient-physician pairings were stratified into 4 different dyads, depending on the level of language concordance in their interaction. First off, we have English language concordance, or ELC, assisted language communication, or ALC, which involved physicians using professional interpreters, partial language concordance, or PLC, and these were non-fluent physicians who either communicated using their limited Spanish-speaking skills, and or had a patient family member facilitate communication. And lastly, SLC, Spanish language concordance, which is our second language concordant pairing along with ELC. Data came in the form of patient and clinician surveys, which collected demographic information and audio recordings for all 34 unique encounters. And then came the time for applying RIAS in a new exciting way, where we assessed the quality of communication by having trained bilingual coders analyze the recordings using established RIAS codes. And then the end product, as explained previously, was a quantitative measure of mean utterances for each metric and speaker. And this takes us right into our results. This table shows our patient-specific demographic data. And what I want to know from it is that 100% of Spanish-speaking patients identified as Hispanic, 79.4% were female, and 67.6% were being seen for breast cancer. This table now shifts to provider demographics information. And here I want to note that 87.5% of providers identified as non-Hispanic, which I thought was an interesting factor to note, just because this could potentially give us some insight into the impact of language versus cultural concordance in care. Something that was also interesting from the provider survey is that 75% of providers who said to communicate with their patients in a non-English language do so at least 2 to 3 times per week, and 100% say to do so at least once a month. And I think this is particularly important because it informs the need for language appropriate care. Now, taking a look at some of the RIAS data, these graphs show the number of times that biomedical information was discussed during the encounter. This metric includes discussions related to therapeutic regimen, medical treatment, and counseling statements. And we see that compared to other dyads, SLC physicians, and physician and patient interactions were heavily centered on biomedical talk, and SLC physicians had almost 2-fold greater mean utterances about biomedical information than ELC physician, despite patients in both groups asking biomedical questions with about the same frequency. In terms of psychosocial information, which included discussions about lifestyle and psychosocial components of health, we see that language concordant physicians are more likely to talk to their patients about this type of information. Now, when it came to emotional dialogue, which included codes for concern, reassurance, statements of empathy, legitimization, partnering, and self-disclosures, we see that all patients expressed about the same number of statements. However, language concordant physicians, especially those in the SLC group, were more likely to express these emotions to their patients. And we see that this in turn translated to the patients engaging in more positive behaviors, which included laughs, direct approvals, compliments, agreements, and understanding. Now, this slide will be a little busy, but I will try my best not to make it too confusing. On the top, we will have information pertaining to the provider, and on the bottom to the patients. And on the series of graphs that you're about to see, the gray bars represent the statements that the clinician expressed, and the orange ones represent what the interpreter conveyed. Of course, ELC and SLC have no orange marks because there were no interpreters involved. And as a reminder, ALC employed professional interpreters, while PLC interpretations came from family members. In this example, looking at speech related to medical information, we see that professional interpreters communicated medical information from the provider to the patient effectively, but we also see that some of the information from patient to provider was lost in translation. Another takeaway from this first set is that family members did not quite do as good of a job interpreting. And when it came to emotional statements, we see a decline in all of interpreters' ability to convey this type of information, which ultimately I believe leads to the discrepancies we see in this last graphic, showcasing partnership facilitation statements, which included cues of interest, checking for understanding, asking for permission to proceed, and opinions. And what we observe is that interpreters did not convey this information efficiently. In conclusion, through this pilot project, we were able to confirm that RIAs can be used as a reliable tool to assess the nature of communication between oncology providers and patients across different languages. While we did identify differences between the language concordant group, Spanish-speaking providers had a higher tendency to engage in more biomedical discussions and to stimulate positive behaviors in their patients. Therefore, our data shows that language concordance facilitates the establishment of more effective and empathetic relationships between oncology physicians and patients. And our analysis also shows that the use of family members for interpretation during the medical visit is inadequate. And while professional interpreters are effective mediators of information, they may interfere to some extent with the development of the doctor-patient relationship. This project in general highlights the importance of language concordant care in oncology and the unmet need for standards to guide the use of non-fluent language skills by clinicians with LEP cancer patients. And future research should explore the impact of language concordance on more specific, more cancer-specific health outcomes, as this work, I think, has an immense potential to inform guidelines for linguistically appropriate care. And with that, I want to thank my mentors on this project, Dr. Pilar Ortega and Dr. Lisa Diamond, as well as our research collaborator and everyone who was part of the Mola Microbase Scholars Program. And I'm not sure if we're taking questions now, but I'll be happy to take any questions whenever.
Thank you very much, Celine. We'll leave questions for the end of the session. What we'll go ahead and do is transition to Melanie Benito, who is currently an undergraduate student at the Wisconsin Alzheimer's Institute School of Medicine and Public Health at the University of Wisconsin. Melanie, you'll hear a bell at the 2-minute mark for your talk, and then that'll allow us enough time to have a discussion for your talk, Celine's talk, and Dr. Correa's talk. Thank you very much. And thank you, Celine, once again for your fantastic presentation.
Hi, everyone. Thank you for that introduction. I'll just be sharing my screen right now. Can someone confirm that they see it? Okay, perfect. All right. Well, as mentioned, my name is Melanie Benito. I am a current undergraduate student at the University of Wisconsin-Madison. The presentation I have for you today is about a research project I currently work on along with my research mentor, Dr. Maria Mora Pinzon. And this project is titled Understanding the Perceptions of Alzheimer's Disease and Related Dementias Among Latinx Older Adults, a Qualitative Study. And on this slide, I just have some quick disclosures. And then first beginning with a few definitions. So dementia is an umbrella term that is used to describe a group of symptoms that affect memory, thinking, and social abilities, all of which can eventually interfere with someone's daily life. Dementia includes several diseases, but the most common one is Alzheimer's, which is a progressive disease, meaning that the symptoms tend to get worse over the years. It typically begins with mild memory loss, but can eventually lead to the loss of the ability for someone to carry on a conversation and to recognize their surroundings. And Alzheimer's is often referred to as ADRD, which stands for Alzheimer's disease and related dementia, because it is rarely present as a sole condition, especially in Black and Latino populations. And aside from Alzheimer's, dementia also includes Lewy body dementia, vascular dementia, frontotemporal dementia, and Parkinson's and Huntington's. And then touching base a little bit on the prevalence of ADRD, in 2014, as you can see from the image below, 12% of Hispanics over the age of 65 had Alzheimer's compared to 10% of non-Hispanic whites. Also, the number of cases of Alzheimer's is projected to nearly triple, being 5 million in 2014 and expected to be 14 million in 2016. And according to the study from the CDC, Latinos will suffer the most from this rise. The number of Latinos living with Alzheimer's is expected to rise from 430,000 to 3.2 million in 2060, which is over a 7-fold increase. And currently Latinos in the United States are 1.5 times more likely to develop Alzheimer's than their non-Latino white counterparts. And this discrepancy is due to several risk factors among Latinos for Alzheimer's. For one, the rate of diabetes is 86% higher among adult Latinos than whites, which according to the CDC suggests that diabetes could contribute to the rising rates of Alzheimer's in Latinos. Lifestyle and socioeconomic factors also put them at a higher risk, not to mention that Latino caregivers of Alzheimer's patients deal with higher levels of stress, anxiety, and depression symptoms. And this is especially important to consider since, as we know in Latino culture, it is usually a family member that acts the role of a caregiver for someone that has an illness, as opposed to like sending them to a nursing home and having a medical professional take care of them. But despite the fact that Latinos are disproportionately affected by ADHD, there are still many health disparities that exist in the Latino population regarding this condition. For one, Latinos are less likely to be diagnosed with ADHD, which leads to less access to treatment options to minimize the symptoms, and they are less likely to participate in clinical trials. And these disparities are the result of multiple factors, including beliefs among Latinx individuals that ADHD symptoms are just part of normal aging, lack of general ADHD knowledge, and limited access to culturally appropriate healthcare services. And then all of that being said, the purpose of this study was to understand the perceptions that Latinx older adults have about ADHD. And in order to help us find this, we asked the research question, what terminology do people use to describe cognitive disorders such as Alzheimer's and dementia? And so this study took place between December 2020 to February 2021 in Madison, Wisconsin. Beginning with recruitment, we shared flyers through community organizations in Madison, and those interested called our PI, Dr. Mara Pinzon, to express their interest, obtain more information, and then consent to participating in the study. And our study did consist of all Spanish-speaking Latinx adults older than 50 years old. They all participated in structured interviews over the phone, where we also obtained consent to record the interviews for analytic purposes afterwards. And so ahead of the interview, participants were mailed 6 cards, each with different colors and images that represented conditions that generally affected older adults. These cards did have the conditions written in both Spanish and English as a way to just help them express themselves in a way and in the language that they felt most comfortable with and understood best in general. So on the screen, you can see the 6 cards that we sent them, and they included the conditions of depression, diabetes, hypertension, memory problems, Alzheimer's, and dementia. And so during the interview, we used a card sorting technique to explore the participants' perceptions about ADHD. They were asked to arrange the cards according to how similar they thought each of them were to one another, how serious they thought each of them was, and any embarrassment that may be tied to each condition. And we also did ask that while they arranged these cards, they kind of explained their thought process to us out loud so that we kind of followed along with what they were thinking. And then once all of the interviews were conducted, we did listen to all of the recordings and use qualitative content analysis to analyze the data. And before I get into like the results, these are just some participant demographics. So our study did consist of a total of 24 participants with an average age of 68 and an age range of 50 to 87. As far as gender, 67% of our participants were female and 32% were male. As far as education, 38% had a technical degree or college education, 38% had finished high school, and 25% had finished middle school. And as I mentioned before, our participants were Spanish speaking, so they originated from Latinx countries, 29% coming from Mexico, 21% from Peru, 8% from Puerto Rico, and 8% from Cuba. And so after analyzing, we saw that most participants perceived ADHD as a spectrum of different conditions. So from what they expressed to us, they saw that memory problems were the beginning stage of the condition that later progressed to dementia. And from there, it kind of just worsened into Alzheimer's disease. And we also saw that this notion was common among participants who had family members with a diagnosis of Alzheimer's. And it is especially important to emphasize that this was the perception held by Latinos in our study, but it does not fall in line with what we previously mentioned in the background regarding dementia being more of the umbrella term and Alzheimer's falling under that. And then furthermore, most participants described Alzheimer's disease as a stage where people experience kind of a loss of oneself and of who they are, and it's characterized by limitations such as the inability to remember events, an inability to connect with family members and friends in the way that they used to, and also an inability to perform activities that characterize their daily lives. And so one of the conclusions we made is that Latinx individuals perceive dementia and Alzheimer's as separate entities. And as previously mentioned, these perceptions are not in line with the current science, even when they knew someone that was affected by the condition. And this just emphasizes the general lack of knowledge of ADRD in the Latino population, which has led to several health disparities within the condition. And so this image is of the movie Coco, which I'm sure we all know, which has one of the few representations of dementia in the Latinx community in the media, which just further stresses how important this topic is to bring up to this population. And all of this in mind, one of our biggest takeaways was that healthcare providers and public health agencies need to adjust their communication strategies to promote conversations about ADRD in this population. And with that, I conclude my presentation, but I did just want to thank my mentor, who I know is listening right now. So thank you all for listening. If you have any questions, just let me know.
Melanie Anito, it's quite clear that you rehearsed that presentation. That was like 8 minutes on the dot. So thank you very much to all three speakers for staying on time. We have, I believe, until 1:20 to entertain questions and foster discussion. I don't see any in the chat box other than one that was already addressed, pardon me, in one of the presentations. So I'd like to open the room for discussion if anybody has any particular questions that they were hoping to ask.
Hello. Yes, I have a question. My question is for Dr. Correa. Probably I missed the first part of your presentation. I apologize if you addressed this question, but I would like to know if there's any way to participate or collaborate with you in your program, and if does, can we do it virtually? Thank you.
Yeah, thank you so much for that question. Yeah, I didn't address it. So yes, so there is opportunity and looking for people. I'm looking for people to expand the program in other areas, because that way we can grow, and then it will be in the entire country. So definitely, I will put my email in the chat, and then we can get in contact, because the program is ready. The main host of the program is the clinic in Rhode Island, and then I definitely the persons there are more than willing to give the program to others. Something about yeah, we can connect via phone or Zoom, but something that has not been a result in a lot of positive, it's doing the program virtually with the patients, because depending on the population that you're working with, but I'm working with a lot of undocumented immigrants, so it's very hard to have the stability of internet and having that connection. So that's not so good as when they have to go to the clinic. So that's something that we are struggling, but depending on the population that you're working, but more than happy to share the program with you. And I'm just putting my email in the chat.
While many of you maybe have questions percolating in your minds and trying to think of the best way to formulate them, I do have a couple of questions for some of the speakers. Celine, I'd like to start with you. I know that your research demonstrated the importance of language and cultural concordance between physicians or any other healthcare providers and patients at hand. And it highlighted the importance of really recruiting and retaining more bicultural and bilingual physicians and healthcare providers to provide a more compassionate and a more constructive rapport with our patients. And you'd mentioned how sometimes the interpreters may not really equate to that same level of care and communication. Did you, in any of your research, come across any potential strategies that people can employ in these language discordant models, recognizing that it might be a longer term objective and one that in the immediate next several years, as we're still developing a more robust pathway for Latino physicians and Latino healthcare providers, did you come across any strategies or any literature that explored how we can mitigate those differences in situations where we have no choice but to employ language concordance. I specifically think of situations where I, as a Latino healthcare provider, may encounter a patient who obviously comes from a different language, a different cultural and linguistic background, and trying to employ cultural humility and employing my own experience as the son of immigrants, trying to explore that within the context of having an interpreter. But as you mentioned, there still is a barrier with regards to language discordance. So how can we as providers maybe help navigate that? And if your mentor is on the call, we're happy to have them, or on the chat, happy to have them explore that along with you too.
Yeah, thank you so much for that question, Dr. Moreira. I think it's definitely a very important question and something that we should all consider when we're treating our patients. I know that although interpreter services, this research did show, are not ideal for communicating that aspect of, just the emotion and empathizing with the patient. I think, like you said, it will take some time to create a workforce that has Latinx physicians who can treat our patients, or physicians who are culturally parallel to our patients. So it's important to also come up with ways to enhance the care that we're giving to our patients without needing to be culturally parallel to our patients. And I don't know if I have a direct answer for you. I think it's such a broad issue and something that we should all think about. But I think that it starts by one, knowing that family members are not adequate interpreters, and that we should for sure use professional interpreters whenever it's necessary. And also that we need more training for professional interpreters to explore the training in terms of more emotional intelligence and how to convey this when it comes to interpretation and translation. Because I think a lot of interpreters are trained in terms of communicating the direct information that has been spoken, but sometimes some of those nonverbal cues and those aspects of how your tone is driving the conversation and how you are communicating with the patient impacts how your patient sees you and the relationship that you can establish with them. So also training our interpreters to try to convey that information and leave space in the conversation for the physician to communicate with the patient whenever possible, and to communicate these nonverbal cues to the patient, I think would be great ways to start. But I do think it's such a great point, and we really do need to work on this a lot.
Thank you very much for that thoughtful response. There is a question that has emerged in the chat. So this one is for Melanie Benito. Do you have any next steps in mind to expand on your findings, and any recommendation on how family members can assist with supporting your efforts to mitigate the gap in knowledge?
I think in regards to the steps for our research, we do still have another research question we're hoping to answer in terms of when patients specifically seek out medical help for these cognitive disorders, and at what point they think it's serious enough for them to go to a medical provider. And then for recommendations on family members, I think it has a lot to do with the way that medical providers communicate with patients, because a lot of times the language that we use is not necessarily language that many family members understand on their own, and it's just communication strategies we need to kind of improve on to make sure that they're genuinely understanding what a provider is communicating to them, and in that way kind of provide better support for the person that suffers from Alzheimer's. But my mentor is on the call as well, so if there's something she wants to expand on, she can go ahead too.
Yes, great work, and yes, supporting efforts to mitigate the gap. We have several resources, and depending on where you're located, there might be some different than others. For example, the Alzheimer's associations tend to have resources available. We are in Wisconsin, so there's very few resources in Spanish, but I just put in the chat a link to My Brain Guide. The My Brain Guide is a toolkit developed by the Us Against Alzheimer's that was designed in Spanish and English simultaneously. This was not a tool that they just translated from English 5 years down the road. And that includes even a questionnaire. Many times we don't know if we should seek help for our family members. And there's a way that you start a questionnaire, like say, hey, should I be worried about this? Should I tell my mom like she needs to seek care? So I love that questionnaire because it's also available in English and Spanish and even over the phone. Many times people say, hey, I cannot see this in the internet. My cell phone is too small. I cannot do it. And people could fill it out over the phone. And that will send resources. So you finish and say, well, maybe you should seek help. Then it will give you a few resources for us to where to seek help. What are the next steps? What are the things that you should know? There's still many things that we need to support and mitigate that gap. And that's part of the work that we're doing. But certainly if anybody's interested in the topic and want to reach out, my email is on the chat and I'm happy to talk more about this. But there's a lot to do and as in everything, like in medicine, but. And I'm curious, I have a question for Ricardo about the telehealth. That's one of the things that we also have been struggling. You know that we even gave some of our participants for another project the tablets with the Wi-Fi, and still we couldn't make it work very. I mean, we did, but it took a lot of going and do visits and figuring it out. Like, hey, let me do a little troubleshooting in person because there was no way. Is there anything that if you could have and money were not an issue that you think might help your program to adapt to the telehealth better?
Oh, I think definitely the money was not an issue. We will be able to put that they don't have to pay for the data. So because many of the times they have cell phones, and this was when I started like, oh, telehealth will be very easy because all of the patients have cell phones. Like everybody here, doesn't matter you're rich or poor, you have a cell phone. But the difference is that some people have cell phones with connection to internet without paying for the data, and then others have to pay for the data. And that's where it comes the problem. So even our telemedicine visit, many of them has been by phone. And the phone also is a problem because also you have like limited amount of minutes that you can use. So have to be very fast, very into the point. And now it's better because now people are starting to come to the clinic. But I don't see if I have unlimited amount. One of the things is provide free internet to everybody with not data charge or anything. So provide free internet, and then definitely provide them with some source of way of connection to that. For example, the VA, I work for the VA, and the VA has done this very successfully. So they provide the bandwidth of the internet to their patients, and they provide the iPad to every patient that want telehealth. And on top of this, they send you a technician to your house to explain you how to use all of this, because we're talking about all veterans and all of that. So and then of course that has been totally successful, but it's a lot of money behind the scenes that these community clinics do not have.
Thank you. That was really helpful. It's about thinking, if money were not an issue, can we address this? Yes.
Yes, we can definitely. We can address it.
There's another question from the chat. One of the presenters from a previous breakout session. The question is, at least in my experience in Northwestern clinical rotations thus far, there's a huge emphasis on using medical interpreters provided within the hospital, even if a family member is qualified to interpret. Celine, is this part of the education at Pritzker? Also curious to hear from any others in medical school, students and educators. I will start, even though the question was directed towards Celine. I can answer, having trained at Loyola for medical school, went to a separate residency program, worked at a community hospital in Chicago, and then trained at and worked briefly as faculty at another academic center in Chicago before coming to Northwestern for being an attending. It's been universally discouraged to utilize family members so long as we can have a qualified interpreter present. Sometimes there are even challenges that do arise, and we have a couple of minutes, so I don't want to take up too much of Celine's time, but I can illustrate an example. In residency, we had an Albanian patient who came with his daughter, and they'd essentially utilized all resources to bring them from Greece, where they were living. They were Albanian immigrants to Greece, living in Athens, exhausted all options there, and flew directly to Minneapolis, St. Paul to get admitted to the Mayo Clinic, which is where I did my residency. We didn't have any qualified Albanian interpreters through our language services in person or over the phone. We had to employ a Greek physician who was very clear on his perspective on how Albanian immigrants impacted Greek society. Needless to say, it was a horrendous experience. And so I think utilizing trained medical interpreters where possible is ideal. Anyway, I will cede the floor to Celine in the few seconds we have left.
Try to type out my response, but I'm such a slow typer. But yeah, I think Pritzker actually this year will be introducing a new part of our clinical skills curriculum. It will be expanding our training to include training being in a room with a patient who needs interpreter services. So that would be part of our clinical skills class to provide care to patients when there's interpreter services needed. And we also have a very important course in healthcare disparities that also contributes to enhancing the care that we provide, having more cultural competence, which I think is also so important.
Thank you so very much. And we are ending on time. So I appreciate the speakers and everyone who contributed to the discussion. We welcome seeing you in the remainder of today's session. Take care.